Welcome. This presentation meets the requirements set forth by the Texas DSHS EMS and NREMT for continuing education covering allergic reaction and anaphylaxis. Please complete the quiz and evaluation found on the last slide or in the video description below. After this presentation, you'll be able to describe the process of allergic response, compare the differences between allergic reaction and anaphylaxis, list and compare the signs and symptoms of an allergic reaction with those of anaphylaxis, describe the treatment of allergic reaction and anaphylaxis, and finally you'll be able to understand the steps to providing epinephrine 1 milligram in 1 ml. Allergic reaction is defined as an abnormal immune response the body develops when a person has been previously exposed or sensitized to a substance or allergen. A person may have three different types of responses. The first one is a local response, otherwise known as a mild response. The body limits its response to a specific area, for example, swelling at a sting site. In a systemic reaction, otherwise known as a moderate response, the reaction occurs throughout the body, possibly affecting multiple body systems. The person may develop hives and swelling throughout their body. The last response is an anaphylaxis or anaphylactic response, otherwise known as a severe response. The body will have a severe hypersensitivity to an allergen where it will perceive the allergen to be harmful. This could trigger an extreme form of allergic reaction involving two or more body systems. The term anaphylaxis is not a lack of protection from a substance, but an overprotection. Once a foreign substance invades the body goes on alert and initiates a series of responses. The first response is the primary response. The first encounter with a substance where cells immediately confront and engulf the invaders to determine if it is allowed in the body. The body will then develop antibodies against these allergens. Through this response, the body will develop a sensitivity. This allows the body to identify if the substance is one of us by using the information acquired during the first encounter. The next response is the secondary response. This is the body's reaction when it is exposed to an antigen for which it already has antibodies. This allows the body to react and kill the substance and cleans up traces of the invasion. Most often, the person remains unaware of this process.
Physical findings for mild allergic reaction with no respiratory distress often includes the following: an itchy, runny nose, sometimes sneezing, an itchy mouth or tingling mouth, a few hives with a mild itch, mild nausea with mild GI discomfort. If left untreated, the mild reactions may become a more moderate allergic reaction. This will include increasing hives, swelling to the lips and eyes, swelling to the skin, along with redness. The person may complain of their throat feeling weird or that it's starting to feel tight. One of the common misconceptions in the treatment of allergic reaction is that all allergic reaction patients need epinephrine. That is not necessarily true. Before we begin treatment, we need to make sure that we perform an initial assessment. We obtain a focus history, including a history of any known allergens or allergies to the patient. If need be, we can go ahead and administer oxygen. We need to make sure that we have effective oxygenation, effective ventilations if needed. We can at this point consider administering a nebulizer treatment if they have continuous bronchospasms. We should then obtain vital signs and, if equipped, apply a cardiac monitor. Make sure that we remove the cause of the allergic reaction. Consider administering diphenhydramine 25 to 50 milligrams PO, IM, or IV. As a reminder, these patients are currently having a mild to moderate allergic reaction and may not need epinephrine, but be aware that they may rapidly deteriorate. Keep in mind to follow your local SOPs or COGs regarding the care of patients experiencing allergic reaction. Physical findings for a severe allergic reaction, oftentimes involving respiratory distress, include the following: increasing generalized hives and swelling, significant swelling to the lips, tongue, or eyes, increased tightness of the throat or a hoarse voice, vomiting or severe diarrhea. If left untreated, severe reactions may become anaphylaxis. This can be identified if the patient begins to experience respiratory distress with wheezing, repetitive cough, or difficulty swallowing. The patient may also become hypotensive with tachycardia and begin showing signs and symptoms of shock. In instances of a severe allergic reaction or anaphylaxis, we must still perform an initial assessment, obtain a focus history, including a history of any allergies that the patient has experienced, administer oxygen if indicated, ensure effective oxygenation and ventilation, and begin to initiate a nebulizer treatment if the patient is having signs of a bronchospasm. The ideal medication would be albuterol 2.5 milligrams. Apply a cardiac monitor if available and obtain vital signs. Initiate IV access, remove the cause of the allergic reaction, and begin treatment of the patient as indicated by your SOPs or COGs depending on your level. For most EMT basics, their scope of practice allows for administration of epinephrine 1 milligram in 1 ml, otherwise known as 1 to 1000. In an adult patient, a dose of 0.5 milligrams may be repeated times 2. If you are not credentialed to administer epinephrine IM, you may use an EpiPen, 0.3 milligrams IM. In a child, the dosage would be 0.01 milligrams per kilogram IM and may be repeated every 5 minutes times 3. Once again, if you are not credentialed to administer epinephrine, you may administer an EpiPen Junior 0.15 milligrams IM. The treatment will continue to be directed towards treatment of symptoms. We can administer diphenhydramine 25 to 50 milligrams PO, IV, or IM to an adult patient, or 1 milligram per kilogram IV, IM, IO to a child. We can continue to administer albuterol 2.5 milligrams via nebulizer. We can administer a steroidal as directed by your COGs. For an adult, 125 milligrams IV of solomedrol or 10 milligrams IV of dextromethasone. For a child, 2 milligrams per kilogram IV of solomedrol or 0.6 milligrams per kilogram IV, IM of dextromethasone. It is important to note that if a patient is experiencing low blood pressure, hypotension, it may be indicated for them to receive IV fluids. For an adult, titrate to effect. For a child, 20 mLs per kilogram. If the patient continues to have hypotension refractory to IV fluid, you may need to consider a push pressor. So now that we are able to identify physical findings in mild, moderate, and severe allergic reaction, including anaphylaxis, as well as the treatment of mild, moderate, and anaphylaxis, we can now go ahead and look at this case study. It is 11:30 a.m. You are responding to a 24-year-old female stung by something at a local zoo. The outside temperature is 77 degrees Fahrenheit, 25 degrees Celsius. As always, we must always be aware of scene safety. Make sure that we are wearing proper PPE. One thing that we want to do is we always want to develop a differential diagnosis prior to assessing the patient. We might want to ask ourselves, does this patient have COVID-19 Is this a traumatic event? Is she having an allergic reaction, or is she having anaphylaxis? Upon your arrival, you note a patient sitting on a bench near an animal enclosure. There are multiple zoo visitors walking by. The patient is wearing a mask. The spouse states that the patient was walking around when she felt a sting on the back of her neck. The patient is alert and oriented. She's able to speak with a persistent cough. She appears anxious and shaky. She states that she is severely allergic to wasp stings. Is there any additional precautions or concerns that may be warranted based on your initial observations? Do your initial findings change your differential diagnoses? Your primary survey reveals no active bleeding with a small sting mark to the back of her neck. She has an open airway with a hoarse voice. She has audible bilateral wheezing with rapid rise and fall of the chest. Brachial pulses are strong and regular. Cap refill time is 2 seconds. Her skin is cool and moist. She is alert and active with a GCS of 15, and she was sitting on a bench when she was stung by an unknown insect. Does the patient currently have any potential life threats? Potential life threats at this time may be the bilateral wheezing and the hoarse voice, along with the possible signs of early shock. The patient informs us that this was a rapid onset of symptoms. There was no provocation. She states that her throat feels tight. She's got some itching and swelling to her neck with no radiation of pain, and she currently gives the respiratory distress an 8 out of 10 on the severity. She states that this has been going on for about 15 minutes. Do we currently see any red flags or any possible life-threatening conditions? Based on the patient's complaints and history of allergic reaction, it is vitally important that we continuously reevaluate the patient for signs of deterioration. You continue to obtain a detailed assessment using the sampler mnemonic. The patient is anxious, shaky, cool to touch, and she is experiencing swelling and redness to her neck and face at this time. She states that she is allergic to wasps and honey. She is currently on a birth control patch. She takes Zyrtec PRN, and she does have an EpiPen that she left at her hotel. The patient has a previous history of allergic reaction to wasps. Her last meal included a hamburger, some popcorn, and a soda. She states that she was stung by something, but it flew away before she could identify it. Her associated risks include possibly stung by a wasp, she is outdoors, and she has had previous allergic reactions to wasp stings. Are there any other questions that you would like to ask the patient and obtain through her history? Some good questions to ask are, what was her previous reaction to a wasp sting, and how severe was her previous reaction? After placing the patient on a monitor, you obtain the following vital signs. A heart rate of 115 showing sinus tachycardia on the monitor, with a 12 lead showing a sinus tachycardia. She has an SpO2 of 95% on room air, an end-tidal CO2 of 33, a respiratory rate of 32, a blood pressure of 92/63, with a temperature of 98.7. Based on your vital signs, ask yourself the following questions. Is oxygen needed for this patient? Why is her end-tidal CO2 too low? Is her respiratory rate too fast? Is her blood pressure normal, or is she in shock? If she's not in shock, why is it so low? Based on the history of wheezing and the low SpO2, it is probably indicated for her to have an albuterol nebulizer treatment. The end-tidal CO2 is below normal, which is normally 35 to 45 because of her rapid respiratory rate. What you don't see is the capnography waveform that is currently showing shark fins. This is indicative of bronchospasms. The patient's blood pressure and heart rate is indicative of compensated shock. This patient is probably starting to experience anaphylaxis. Your detailed physical exam revealed the following. She's got moist mucous membranes, redness and swelling to her neck. Her pupils are equal, round, reactive to light. Her ears are unremarkable, though she does have some redness to her earlobes. She's got mucus in her nose. She has a sensation of swelling to her throat and a hoarse voice. She is experiencing bilateral wheezing with rapid respirations, good rise and fall of the chest, and moderate distress. Heart sounds are normal with no murmur. Her CMS is intact. She's got normal cap refill with a rapid brachial pulse. Abdomen is soft and non-tender with hyperactive bowel sounds. Her pelvis is stable. She is experiencing generalized hives to her upper extremities with normal cap refill, and she's got normal cap refill and no hives to her lower extremities. Based on your assessment findings and your field diagnosis, how would you treat this patient? Is the patient experiencing an allergic reaction, or is she experiencing anaphylaxis? Based on your findings, epinephrine is a priority for this patient as there may be rapid deterioration. What are your goals for this patient? Should the patient be treated with immediate supportive care? Should you continue to be prepared for more rapid deterioration? Should you promptly identify shock for patients who will require escalation of the therapy? The patient is continuously monitored en route to a local hospital where her blood pressure increases to 108/72 with a decreasing heart rate to 110. Respiratory rate decreases to 20 with her end-tidal CO2 of 36, showing continued bronchospasms. Based on your COGs and SOPs, does this patient require repeated treatments? Due to the continued bronchospasms, albuterol 2.5 milligrams may be repeated, as well as a second dose of 0.5 milligrams of epinephrine during transport to the emergency department. At the hospital, the patient was given an H2 antagonist, otherwise known as Tagamet, to treat continued itching and urticaria, as well as her upset stomach. She was observed and discharged from the emergency department with an anaphylactic reaction secondary to a sting from unknown origin.
In order to administer epinephrine 1 milligram in 1 ml via IM, you will need the following: an ampule of epinephrine, a 3 to 5 cc syringe, a filtered needle, and a secondary needle to provide the injection. First thing you will do is you'll take a 4x4, sterile, non-sterile. There's some fluid up on top, so we need to go ahead and slowly swirl the fluid to the bottom. All fluid is now gone. You will now take your 4x4 You will snap the top of the ampule off. You can place that down. Take your filtered needle, and you will go ahead and remove the contents of the ampule. There's different techniques to doing this. This is just one technique. This should give you 1 ml of epinephrine, 1 to 1,000, or 1 milligram in 1 ml. After you've done that, replace the filtered needle. Get the needle that you're going to require for the injection. Again, you currently have 1 milligram of epinephrine. Remove the cap. Inject the patient. 0.5 milligrams.
As always, please follow your local COGs or SOPs. In conclusion, remember that not all allergic reactions are the same. Allergic reactions are common. There's distinguishable differences between allergic reaction and anaphylaxis. The treatment of allergic reaction and anaphylaxis are also different. Keep in mind that not all allergic reactions require epinephrine. Continuous reassessment of the patient is important due to the possibility of rapid deterioration. It is important that we look for these subtle changes in patients' vital signs and signs and symptoms that may potentially point to shock. The steps to providing epinephrine 1 milligram in 1 ml must be learned if EpiPens are not available. Keep in mind that you must follow your local SOPs and COGs when it comes to credentialing in the administration of epinephrine IM. If you have any further questions, please reach us via text message on our visit system. Our on-duty virtual instructor will answer any questions you may have. You may send a message to 210-660-7603. Again, the number is 210-660-7603. Please capture the QR code to complete the quiz and class evaluation. Once you've completed the quiz and class evaluation, a certificate will be emailed to you. Thank you very much for your time, and please visit our website at www.archangelse.com. Have a good day.